It's 10-10-25. This is the Room Now podcast. I'm going to say it again. I like the way it sounds. 10-10-25. This is the Room Now podcast. I'm Jack Cush with Room Now. This week on the podcast, new thoughts on HMGCR antibodies. Sure you were looking for that. What about the FDA? They got real busy this week, probably because they had to go on vacation with the government shutdown. Geez, either they're looking at the want ads or on the beach. We got to get the FDA back to work. But before this week, they were pretty busy with new approvals. And in this podcast, I'm going to eat crow. You know, the idiom means that I'm going to have to swallow my previously hard, incontrovertible opinions on things like MRI and drug weaning. That and more on this week's podcast. Lupus at the top. You know, last few weeks we've been talking about the hazards, and they are evident, they are extreme, and they are devastating of multimorbidity. And now we got a meta-analysis of 3 studies in lupus. Multimorbidity, 3 studies, 1,100 patients, showed that higher Charlson comorbidity indices was a strong independent predictor of mortality, all-cause mortality, being 4-fold higher with the highest CCI levels. CCI being Charlson Comorbidity Index. In lupus, the most common comorbidity seen in this cohort of 1,175 patients was diabetes, cardiovascular disease, lung disease, renal disease, and CNS disease. Again, you should be measuring it. You should be worried about it. A small study from Pakistan looked at something you all know, and that is what's the differential outcome with induction therapy in lupus for lupus nephritis when you use either mycophenolate or cyclophosphamide. 62 patients induced with their nephritis with either mycophenolate and cyclophosphamide given at standard doses, and then after 6 months of the induction, everybody was treated with mycophenolate for the next 6 months. The 12-month outcomes: complete renal remission, 77% with mycophenolate versus 29% with cyclophosphamide. Yeah, I think that cyclophosphamide has fallen by the wayside, has it not? So the FDA, as I mentioned earlier, has been very busy with 3 FDA approvals. You know, last month, September, we did a lot on ILD. We had a journal club on nerandomilast, the PDE4 inhibitor, and it was approved this past week by the FDA for treatment of adults with idiopathic pulmonary fibrosis. It was based on 2 RCTs, the Fibroneer IPF study and the Fibroneer ILD study. The latter is the one we discussed in Journal Club. I think that we like that data. The investigators and the discussants, Shervin Asasi and Toby Maher, they like nerandomilast. It seems to have as good a response as anything else, but is better tolerated. In fact, maybe the efficacy responses look a little bit better. But like all ILD clinical trial data, it shows a flattening of FVC as their primary benefit, does it not? So again, it showed a slowing of lung function decline in both interstitial pneumonitis and patients with progressive pulmonary fibrosis. So again, that's good news. Another FDA approval was for severe alopecia areata, another JAK inhibitor, this one called duroxolitinib, a drug that we won't see in rheumatology but is out there, again, attesting to the efficacy of JAK inhibition in patients who have the autoimmune scalp disorder or skin and hair disorder of alopecia areata, and even the worst form, alopecia universalis. I've been using this for years with good success at standard doses. A lot of the clinical trials done with tofacitinib and other JAK inhibitors use high doses, the doses you don't want to use. I use the standard doses, and patients generally benefit in my experience, but we're going to have a number of these drugs approved for alopecia areata and universalis going forward. And lastly, last Friday, I think it was, the FDA announced that guselkumab, the IL-23 inhibitor, was FDA approved for use in pediatric psoriasis and psoriatic arthritis in individuals with active disease over the age of 6. That's either plaque psoriasis or active psoriatic arthritis. Pretty much the same indications and safety issues, nothing new raised there, but this certainly expands the treatment possibilities for pediatric patients with psoriatic disease and is welcome news. Another drug in development for psoriatic disease is another IL-17AF inhibitor from MoonLake. It's called sonelokimab. It's a nanobody. Other than saying it's a nanobody, I don't know what that really means. I know it means it's a smaller molecule, but I don't know that it translates to better clinical effects. The original idea was it would be better tissue penetration and maybe better safety and efficacy. I don't know if that's really true. I haven't seen evidence to that, and I've looked at a few studies on this. Anyway, the phase 2 ARGO trial in 207 adults with active psoriatic arthritis treated with either 60 or 120 milligrams of sonelokimab. They either had an induction or they didn't have induction. They tested it against placebo and against adalimumab. I didn't see the adalimumab results, but as far as its primary endpoint, ACR 50 at 12 weeks, it did very well. 60 milligrams, 46% ACR 50. The 120 milligram with induction group, 46% ACR 50. Placebo was less than half that at 20%. Same thing for the PASI 90 results. The 60 milligram, 77% PASI 90s, 120, 59%, placebo only 15%. So this drug looks good, and we'll see where it goes. As far as the FDA, it's not yet up for FDA decision, but this data, phase 2 data, certainly marches them closer to the goal line, does it not? A Taiwan study looked at one of my favorite topics, and that is, can you get reactivation of Hep B or Hep C when you use biologics? Talked a lot about that in the past. So this comes from Taiwan, where there's higher endemic rates of Hep C and Hep B and higher rates of reactivation. They did this in patients with psoriatic arthritis and psoriasis. A total of 5,500 treatment episodes. Not a little more than half of them, 3,197, were either on a biologic or a targeted synthetic, and they found a reactivation rate of Hep B of 10.6%. and a Hep C reactivation rate of 9.9%, basically 10%. And that's higher, I think, than what we would see in the United States, Western Europe, UK, Scandinavia, where I think the numbers are 2% or so. There, again, high-risk group had reactivation associated with TNF inhibitor use. Again, they saw it with all the biologics, IL-23s, IL-17s, TNF inhibitors, highest with TNF inhibitors, and those who are Hep B surface antigen positive, that's active infection. They should not be getting biologics without receiving prophylaxis and antiviral therapy, right? But if they're the ones who have the, they have core antibody positive, Hep B surface antigen negative. They have surface antibody positive, meaning they're immune, either by naturally or by vaccination. Those people can get it pretty safely. But anyway, they found reactivation higher with TNF inhibitors, B surface antigen positive, E antigen positive, concomitant immunosuppressives, and those who were without viral prophylaxis. That's, again, in a high-risk population. HMGCR antibodies we've talked about in the past. They became first, I think, known to me from the Johns Hopkins groups when they showed the association with statin myopathy. So HMGCR antibodies is associated with immune-mediated necrotizing myositis or myopathy. In this meta-analysis or review of 78 patients, some were from their site and they put some others in. They showed that really a few things that I think, and the other thing about HMGCR antibodies, I should have said at the outset, is it's not just statin-associated necrotizing myopathy. It is associated with other necrotizing myopathies and other clinical profiles, and that's the point of this report. 31 had higher activity scores, less muscle weakness, more ILD, more arthralgia, weight loss, and rash. So they had a lot of extramuscular symptomatology, did they not? But less weakness. 12 out of the 78 had what looked like a muscular dystrophy-like presentation, earlier onsets, longer duration, less myalgia, and less extramuscular symptoms. So the profile of HMGCR antibodies isn't that just of necrotizing myositis associated with statins, it has a range of other possibilities that we need to take note of. I put up a nice report this week that was from BMJ, Evidence-Based Medicine, where they did a meta-analysis of tramadol. This is very distressing. We are in the pain business, are we not? What are you doing to treat pain? When I'm with the fellows in the young rooms, they don't use any nonsteroidals. They hardly use any acetaminophen. They never use narcotics. Most of us don't use narcotics because we're afraid of being called in front of the judge or chastised by someone that overlooks our work. The question is, our patients have tons of pain. And what are we doing about it other than, well, I'm going to treat the underlying inflammatory, immune-mediated disorder and the pain will take care of itself? Not always, Cindy and Charlie. And now it gets more distressing. Tramadol, a weak narcotic, some of you use. This meta-analysis basically says that this weak opioid analgesic is really not worth the time and effort. 19 clinical trials, 6,500 patients, all with chronic pain. The pooled analysis shows that while tramadol eases pain, the effect was really paltry and below the clinically important difference as far as pain relief. So modest effects on pain, but on safety, there was considerable amounts of safety signals, including serious things, including cardiovascular events, where there was a doubling of events. A lot of nuisance side effects with tramadol. The bottom line, it's hardly clinically effective. Why would you use it? Was the point of the paper. I still think we're in trouble. I still think we need to have strategies to deal with pain. I didn't put in this week because of time and number of reports. There was another cannabis-related report on low back pain. A fairly well-designed clinical trial with good outcomes. The readout on pain relief was hard to understand. That's why I didn't put it up. But it was significant. Cannabis did lead to a significant reduction in chronic low back pain compared to placebo controls. Is that the answer? We got to work at this. 2 stills reports. One from Germany, 124 patients, gave you a profile, and I think this is important. They were diagnosed with a disease duration of 7 years. They had a diagnostic delay of 2 years. Really, stills should not be that hard to diagnose. 2/3 were treated with biologics, 84% responded. 81% were inactive after biologics as measured by CRP. The bottom line of this report was more patients are, the next report, more patients are getting earlier treatment. Patients said they were inactive 80% of the time. Doctors said they were inactive 35% of the time. When patients said they were active, they had things like back pain, fatigue, weakness, and patient declared inflammation of the joints. So maybe the doctors were right, in that they're judging it on fever and CRP and sed rate. Patients are any symptoms that bother them, and that sounds to me a lot like secondary pain, type 2 pain, fibromyalgic pain, long COVID pain. Another report, an ACR Open from Italy, was a retrospective analysis of 42 patients with adult stills treated after 2010, when the guidelines started to recommend that IL-1 and IL-6 inhibition should be given as first-line therapy. So they looked at their patients who received IL-1 inhibitors. Most of those, I think, were anakinra, either in the first 6 months, and then others who received it in the last 6 months. Early use of IL-1 inhibition was associated with greater achievement of clinically inactive disease, CID, 2/3 of patients versus 1/3, 67 versus 38%, was not significant, but these are small numbers. And they were more likely to discontinue their steroids in the first 6 months. When the patients suspended their IL-1, there was 10 who flared, 10 out of 42. And most of those flares that were observed, the vast majority of them were with IL-1 suspension or with IL-1 inhibition spacing, prolonging the intervals. Again, the hard part about stills is knowing when to stop. And, I like to treat them for 8 months. I need to see no activity. I need to see totally normal, sed rate, CRP, hemoglobin, hematocrit, platelet count, maybe ferritin, and a normal aldolase, because I've talked before about aldolase as a biomarker in Still's disease. Nature Reviews in Rheumatology, a nice report by Diane Lacalle and colleagues, reviewed GLP-1 agonist use in rheumatology, showing that, yes, they work in diabetes, obesity, but across the board, there's improved survival with a reduction in major cardiovascular events, also renal events. The issue at hand is there an anti-inflammatory and chondroprotective effect to GLP-1 inhibition? Seems like that's the case with knee OA and knee pain. And while they have been shown to be beneficial in gout, GLP-1s do not prevent gout attacks. They definitely improve gout survival and mortality rates. And we definitely need more research in inflammatory disorders like RA, PSA SPA, and lupus. And that's hopefully going to be in the near future. A nice report from Dan Solomon's group where they looked at predicting D2T RA patients. And this is, they tested or developed criteria and predictors using the BRASS patient data set of 700 patients. 16% of their population met the EULAR definition of D2T RA. And then they validated their measures on the certain cohort, which I think started out as a corona data set of over 2,000 RA patients. And there they had 28% who were D2T RAs. And of all the things that were predictive for D2T RAs, patient-reported outcomes. That includes functional status, pain, fatigue, global disease assessment of activity. And when you string those together, it has a predictive accuracy that was moderately high with a C-index of around 0.63. So we can predict D2T RAs. And again, I think that when we talk about D2T RAs, I like to talk about PIRAs and NIRAs. NIRAs are the D2T RAs that have non-inflammatory refractory RA, and those are fibromyalgias, right? And chronic pain without inflammation and damage and active immune-mediated inflammation. And then you want to find PIRAs, the persistent inflammatory refractory RAs, and they have acute phase reactants and evidence of subclinical or clinical synovitis on ultrasound or imaging. So the next study, OptiBio, was a randomized 5-center study in Spain that looked at adult RA patients in sustained remission on a stable biologic DMARD, and they underwent a 1-to-1 randomization. Almost 200 patients, who were either continued their stable biologic DMARD, and then the optimization group, which really means a dose reduction group. So either they reduce the dose or reduce the interval without stopping the drug. And it turns out in this study, there were 39 flares out of 195 patients, roughly equal between the optimization group and the continued group. 23% versus 17%, not significant, P equals 0.33. So why, again, now I'm eating my own words. I'm saying do not stop or reduce these therapies. RA is too hard to control. I'm going to say that this data was stacked with a really special group of people in deep, deep remission. They had a mean SDI score, which is the same as CDI, of around 3. They had a disease activity by CRP that was 1.72, very, very low. They all had swollen joint counts of 0 or 1. And all of this activity of being in great control was for, I think, a median of 21 months. So long-standing, deep remission, yeah, if you want to stop, you probably won't do so bad. But how many of you have patients in deep remission with a DAS score of less than 2, 1 point something, and a CDI score of 3 or less, that's remission in my book, for more than 21 months? It applies to very few people. While I'm going to eat my words here, I don't know. You can remind me of this when you see me. I like this report from Dennis McGonigal's group reported in Rheumatology, which again talks about D2T-RA patients, 254 of them, and a subset who had polyrefractory, meaning they failed 3 or more biologic or targeted synthetics. They only had half x-rays on 114 with a follow-up of 9 years. And what they found was not all the D2T-RA patients had worsening of their x-rays. The ones that had worsening of their x-rays were the PIRAs, the persistent inflammatories, and they had progression of their sharp scores, modified Van der Heide sharp scores of 3.3 in PIRAs versus 2.4 in the NIRAs, and that was significant. So there was an independent association with rapid progression of x-rays with older age and swollen joints. Rapid progression was observed in 50% of the polyrefractory RA patients. That was 14 out of the 114. So, well, I guess the polyrefractory would have been 28, right? 14 out of 28. 50%, but only 19% of all the D2T-RAs. So what's the deal? The point is, not all D2T-RAs, as met by the EULAR definition, are going to have rapid progression. And we need to have rules for more aggressive treatment because there's a subset of D2T-RA that's going to have very slow or no change in their x-rays when followed over time. Speaking of x-rays, our last report is on whole body MRI. I keep seeing these reports. So I put a nice review article up that you can read. It's really extensive. Do I do MRI? Never. Why do I need to do an MRI? To find out what's going on in hand RA? I'm sorry, I've never done it. I don't think I'm handicapped by it. I have colleagues that do it on occasion because they want to find, I don't know, some synovitis that they're going to do something about. I'm very aggressive to begin with. Do I do MRIs on non-radiographic axial spas? Nope. But you might. Well, here's this tool, whole body MRI, and it's being used more and more. Who would you use it in? It's being used in JIA, where kids are kind of hard to examine. It's being used in patients with deformity. It's being used in obese patients who have chubby fingers that you really can't tell, right? And maybe you don't like doing or can't do ultrasound. The real reason is that you can screen the whole body, you can make diagnoses, you can stage, and you can do surveillance. Whole body MRI really refers to head to toe coronal images that are acquired sequentially at multiple stations that are 25 to 50 centimeters each, and then the computer stitches them together to give you a whole body image. When you include the setup time of 5 to 10 minutes, these whole body scans take 45 to 75, depending on whether you do the whole body. Now, you can make them shorter by truncating it and say, I just want to do from, neck to knees, right? Or orbits to knees, or shoulders to hips. And that's a way of doing this. They have been advocated for in RA, SPA, JIA, and identifying osteitis. It does pick up both joint and skeletal involvement and also stuff at other extraskeletal sites. And the advantage is it picks up subclinical disease. It does a qualitative assessment of joint disease or inflammatory disease. It gives greater detail, especially for bone lesions and axial lesions. And there's overall less ionizing radiation. Am I going to do it? No, I don't know. I'd rather wait until you tell me it really pays off and it's not that expensive, because really what we need are protocols where they can be used for screening, diagnosis, staging, and surveillance. And we need utility studies in practice to show that it's really worth doing. Until then, I'm going to rely on conversations and what I read. Speaking about what I read and what I learned from reading, Room is going to be at ACR 25. We've got a lot of coverage. Our faculty is gearing up. We've got a lot of KOL perspective videos. We're going to be covering the key clinical trials. Watch for the daily recaps, roughly 5 p.m. Central Time every day, starting Saturday, Sunday, Monday, Tuesday. where you can hear what happened that day at the meeting. And then after the meeting, topic reports on RA, PSA Spa, and others. Follow us on Twitter. I think you're going to like it. Lastly, registration is open for Room Now Live, February 8th and February 7th. That is Super Bowl weekend. We end at noon on Sunday. You'll be home in time for the Super Bowl. It didn't hurt anybody last year. I had a good time, and I had a big party at my house. So we'll see you Super Bowl weekend in Dallas for Room Now Live. Until then, take care of yourselves.